Good morning. I'm Ed Jackson, Special Assistant to the President at Cleveland State University for Health Affairs and co-director of the NeoMed CSU Partnership. On behalf of our presidents, my co-director, Dr. Sonia Harris-Haywood, and distinguished friends, we extend a hearty welcome to you. There are two individuals in the audience that I think I must give special recognition to at the risk of actually being embarrassed by the rest of you. All of you deserve your own announcement. But we have with us today Carolyn, the Chief of Staff at NeoMed and Senior Vice President for Diversity. Would you raise your hand, Carol, so people can see you? And we have with us today the Dean of the College of Science and Health Professions at Cleveland State University, Dean Bond, would you? Yeah. I think I'll stop there, though I probably have already stepped in over my head. We are so excited about this conference today. We applaud you, and we're proud. So with this introduction, I'll turn the program over to the leader of this coalition effort, one of the leaders. Thank you.
Thank you. Good morning. My name is Frances Mills, and I'm the director of the Cleveland Office of Minority Health. And we welcome you this morning, and I would like to extend an invitation to Ms. Angela Dawson to extend a welcome to you from the Commission on Minority Health.
Good morning. I have you want me up there? Yeah. I have a significant bilateral hearing impairment, so I need your help. Good morning. Good morning. Wonderful. Certainly on behalf of the Ohio Commission on Minority Health, we are extremely excited today to be here for the kickoff of the Minority Health Month for the Cleveland Local Office of Minority Health, which is housed in the Cleveland Health Department. How appropriate to kick off a symposium addressing disparities in equity when our national theme is partnering for health equity. Now, Dr. Jackson, we have to say thank you to you for your vision, because you have known what the issues are for decades. And we're so glad that we are coming together to address this. Now, if I had my way, I'd turn the heat off, take away the refreshments, and lock you in this room until you began to establish creative collaborations and effective strategies to implement equity, disparity, implementation and policies within your organizations and across your organizations, because it's been too long for us to continue to meet and meet yet again. So we need to wake up and have our say. It's not okay that we continue to see the death of racial and ethnic populations at unacceptable levels in this state. It's not okay. And I don't want you to get at ease in Zion or comfortable in your chair. I came by to do a welcome. I'm saying to you, we are appreciative of the support of the Cleveland Health Department. The commission has poured over $1 million in the local Office of Minority Health since its inception. We know that the work must be done. And even though we are at the state, you need to hold the state accountable. You need to hold the county accountable. You need to hold health systems and hospital systems and anybody that has the audacity to say they're in the business of health care. And health care, as you know, is impacted by where we live, work, play, and pray. And we need to be about holding systems accountable, because you can't get healthy in unhealthy living environments. I know I sound like a preacher, and it's okay. Sometimes you need a sermon to wake yourself up. So certainly we extend greetings to Director Gordon and Commissioner Sisoak, and as well as Ms. Natoya Walker-Minor. Certainly, let me do the correct thing, and on behalf of the Commission on Minority Health and our board and staff, we bring you greetings. Dr. Hall, our chair, is a practicing physician. He sees the issues of disparities every day. But I want you to take this as an opportunity not to do the same old thing, sitting in the same chairs, looking at the same people you've been looking at, creating strategic plans that go nowhere. Let's talk about making Cleveland, Ohio, the healthiest city in the nation. Let's talk about undergirding and uncovering policies that have undergirded dis-ease in this city and in this state. Let's talk about a different approach. So when you get together at your tables, I want you to fasten your seatbelts, because I want you to understand that there's a person in the room who I am blessed to be able to call my friend and my brother. I would be remiss if I didn't acknowledge Mr. Chip Allen, the director of the Office of Health Equity at the Ohio Department of Health. Get ready, because he's about to give you a message, and I personally don't care if you're comfortable today. In fact, I want you to get uncomfortable, because we don't do anything until we're sick and tired of being sick and tired. I want you to know that the work of this office is fueled by someone who is steadfast, immovable, always abounding in what needs to be done, and that person is Miss Frances Mills. I'd like her to come forth at this time. You need to know that she's my hero. She's in season, she's out of season. She don't care if they on her side or not on her side. She know work has to be done. We present her with the gold medal because she has aspired and achieved. Yes. Have a busy day.
Let the church say amen. I want to turn the mic over to my partner. When we begin to talk about equity in Cleveland from an educational standpoint, from a health standpoint, system standpoint, you see people in rooms all the time together. And sometimes you'll hear something and you'll look across the room and you'll catch a person's eye. Lena is that person for me. We begin to have conversations about potentially doing this symposium about 1.5 years ago. And it is actually, today is the day. And so I'm pleased to turn the mic over to her so that she can give an overview of the day, and then I'll come back with a few words.
Yes, so thank you for getting church up in here early this morning. Thank all of you for trudging through the rain, through the intermittent snow in the middle of April. So thank you for being here today. It's all for an important cause. So as Frances stated, I am Lena Grafton. I am the Community Education and Engagement Coordinator and Adjunct Faculty for the NeoMed CSU Partnership for Urban Health. And you are here today basically because of a conversation that started with Frances and I. So thank you. And I thank you, Dr. Jackson and Director Dawson, for being here and your support as well. So just to get things started, I know we're running a little behind. So to get back on track, a few housekeeping items. The bathrooms are to my left. So if you go out into this hallway, you will see that. For those of you who are not familiar, CSU has free guest Wi-Fi, so please make sure that you tap into that, because we will be asking you to use your cell phones in just a little bit. And if you could silence your cell phones at this time, that would be very helpful. And there is a program evaluation in your packets. So those of you that parked in the West Garage parking lot, we are validating your parking only once you submit your evaluation. So as Francis and I started to have this conversation about health equity, we wanted to make sure that we had ample support and resources and able to do that. So we could not be here today without our funders, and that is the Cleveland Foundation, the Ohio Commission of Minority Health, the NeoMed CSU Partnership for Urban Health, and the American Heart Association. So thank you very much. In alignment with that, there are other significant people that have come together with us, and we are calling ourselves the Health Equity Coalition of Greater Cleveland. Will you please stand? Yes. So these like-minded people that you saw standing are part of the reason that we're here today. So I want to thank you for your time, your effort, and your resources.
I guess I would be remiss without starting this day on a note of thanks. And I'll say on behalf of the Cleveland Office of Minority Health, the Cleveland Department of Public Health, and the great city of Cleveland, we welcome you. I would like to thank Lena for partnering with me on this endeavor and for the support from NeoMed CSU Partnership. Thank you to Dr. Jackson, Dr. Greg Hall, Dr. Harris Haywood for your hospitality and support. To the Planning Committee, we have been a happy band of opinionated and passionate warriors who beat the drum of health equity every day. So I thank you for working with us. Thank you to our distinguished keynotes and panelists, and I thank the audience for being here. It is Minority Health, and it's fitting that our efforts center on equity. The theme, like Angela said, is for 2018, Partnering for Health Equity, which highlights partnerships at the federal, state, local, and tribal and territorial level that help reduce health disparities in health and health care. April is a time for us not simply to talk about the health status of racial and ethnic minority populations, but to begin to do something, to move beyond our intent. In places around town, there are billboards that read, "Celebrate life, embrace good health, and promote health equity." But we know that there are some of us who cannot celebrate life or embrace good health. And so it is up to us to help promote health equity. I contend that achieving health equity is not about intention, but action. Why did we take a multi-sector approach? If you've read your agenda, you'll be hearing about frameworks that will help advance equity in various sectors. On any given day, we could have focused simply on health or addiction or mental health or LGBT issues, lead, air quality, or criminal justice. Our focus today is multi-sector because we're bleeding everywhere. Systems are failing when education is broken, economics is broken, when healthcare is broken, when the government is broken. That's where inequities thrive, and when inequities thrive, that's where people perish. Achieving equity comes from a desire and will be activated only on a personal level, an organizational level, and a systems level, not individually, but collectively and simultaneously. And so your job here today is to engage, but to ask yourself, what will I do to promote health equity today? Throughout the day, we will give you an opportunity to use some technology. So if you have your phones with you, take them out, and we want you to do two things. We want you to text 22333. And when you receive a message, just somebody raise their hand.
They have to put that in the text and then, okay.
Go ahead.
So there's two pieces. So instead of a phone number, put in 22333. And the message that you include is HEQCLE. HEQ, it should be on the screen. CLE is the message that you will send. 22333 is the phone number, and the message is HEQCLE, and click send.
Okay. So throughout the day, did you get a message? All right. We're going to do a practice session of a pulse check. And so, Brenda, if you would cue up our first question. This is a practice question to see if we can use this technology throughout the day. Okay.
Is it coming up, Brenda? Okay. Well, while we are waiting for the technology to catch up with us, I want to say thank you to a few other people that I saw come into the room. So I teach urban health to pre-med students, and there are a few of them that are here that are not even taking my course this semester, so they don't have to be here. So I just wanted to say thank you to all of you for being here, and thank you for everyone in the audience for taking the time to work with us. And the important piece of today's session is moving from intention to action. So by the time we leave here at the end of the day, we would like to have a plan on what our next steps are and what those need to be.
We're going to move on while they work that out. So when technology doesn't work, we move on. And we're going to start with our first presenter. From the Ohio Department of Health. He has a long bio. If you look in your program, you can read it. But I will say this, that I have been a longtime admirer of Chip Johnny Allen from the Office of Diversity at the Ohio Department of Public Health. In this position, he has been responsible for developing agency-wide goals, objectives, and strategies to eliminate health disparities and promote health equity for all Ohio residents. He works in partnership with national public health organizations, state cabinet level agencies, and a variety of public health programs to target services to disenfranchised groups, measure program performance, and assess outcomes. I'm not going to read the rest of it, but I'm going to say that every year when I'm in Columbus for the Minority Health Month Expo, I look forward to seeing you and having conversations about equity across the state. And so I want to introduce to you my colleague and friend, Mr. Chip Allen from the Ohio Department of Health.
Good morning. On behalf of the Ohio Department of Health, our director, Lance Himes, it's so good to be back here and to see the good work that you all are doing in Cleveland. I have to say thank you to the Health Equity Coalition of Greater Cleveland. You all are doing some fabulous work. I also have to say thank you to Director Dawson. She had to leave, but as you all see that we've already had church. And one of the things I've always asked is that anytime I have to speak, I don't have to follow her because she's just that good. But it's a pleasure of actually working with her every day. There are so many of you all in the audience that I have a great amount of respect for. You all have been doing this work for years. And so many of you, I can't name you all, but people like Myron Bennett and Michelle Shaw and Sabrina Roberts, Erica Chambers, just so many of you, people who have just really put their heart and soul into this. I also know that there are other friends that I've known for years from the College of Worcester who are here to support me, as well as family. So I want to thank you all for being here and also being able just to share some ideas briefly about how we can advance health equity. Now, part of what I want to do today is to really talk about how do we really think about this issue. But beforehand, I just want to say it's good to be back. As some of you all know, I'm a native Clevelander. I'm a kid that grew up on Kinsman, and it's certainly good to be back. So when I think about being back, and I think about all the people, after all, this is Believe land. So you see all the things that I think of when I think about Cleveland. And yes, you will see a corned beef sandwich and Polish board. So we can't really get good food sometimes outside of Cleveland in that manner. So I just want you to know that as any real Clevelander, I will be paying homage to those businesses that serve those foods on my way out of town. So when we start just talking about health equity, one of the things I just want to make sure is that we're real clear in terms of definitions. I'm going to just turn just a little bit so I can see the slides. When we start talking about health equity, we talk about a situation where everyone has the same opportunity to achieve health. But oftentimes when we talk about health equity and we describe it, we really describe health disparities, and that is the disproportionate rate of diseases that we see in health outcomes of certain groups. The reason why we have problems is because of health inequities, and when those disparities are the result of the absence of the things that you and I need to stay healthy. And also that means the social determinants of health. So as I start this presentation, I want to think about putting it in perspective. And growing up in Cleveland, I'm very aware of the different areas. Think about it. East Cleveland, Glenville, the Huff area, Kinsman. In order for health equity to really exist, it means that the people in those areas would have the same health outcomes and opportunities for good health as people in Beechwood, North Olmsted, and Shaker. Is that really the case? And if not, then we have to do this. There are two main questions that I'd like you to consider as we take this journey together. The first one is, what have you done for me lately? As all you all know, that's Janet Jackson, and I think that when we begin to ask that question to decision makers and people who actually help to determine how well and how long we live, it really gives it a whole different meaning. And the other critical question is, have you been miseducated regarding health equity? So, what do I mean by that? Some of you all may recognize this. This is Dr. Carter G. Woodson, one of the most brilliant minds that this country has ever produced. And he talked about thinking. He said when you control a man's thinking, you don't have to worry about his actions. You don't have to tell him not to stand or go here or go yonder. He will find his proper place and stay in it. You don't have to send him to the back door. He'll go without being told. In fact, if there is no back door, he will cut one for his special benefit because his education makes it necessary. So when you think about that, think about the times that you knew that there were some things that you wanted to do to advance health equity, but somebody told you to stay in your lane. They told you that you shouldn't really be concerned with those other things because you have this part of the problem. I contend that if anyone says that, that is a bad omen to let you know that the miseducation process has begun. So, and I want to talk about some of the things that we have to deal with when we think about health equity. As all of you all know, we have a terrible problem with opiates. It is so bad that we have people actually overdosing in the streets. We have a problem so bad that first responders can't even touch the substances because they too may be in danger. And then when you think about the opioid epidemic, they talk about there were really 3 waves that's come. The first wave, like in the 1990s, where we actually had prescription overdoses, then the rise in heroin, and now what we deal with in terms of the fentanyl issue, right? And so you see that in terms of the graph, that is a really steep incline. However, I continue to you that when we talk about racial and ethnic minority populations, the question is, we have to think about the issue of incidence or prevalence. Incidence or prevalence. So, incidence, of course, is the number of new cases of any disease in a given time. And prevalence is the number of existing cases of a disease over a given time. So when we think about this whole issue of opioids and the thing that we have to deal with in terms of minority communities, is it something new? They talk about the wave. And we have the president, we have all of our major institutions actually declaring a war on this, as they should. But when we start thinking about the issues of racial and ethnic minority populations, when we talk about a wave, minorities feel they've been drowning in this water of substance abuse before there was even a wave. Here's the other thing. Think about it. We have been dealing with issues of drugs in our community for years. In fact, you know you have a problem in dealing with this issue when the drugs that they're now focusing on actually is not even called the same name. See, there's an issue about heroin. We don't even call it that, it's heroin. So you know that if you talk to somebody and they say that we have a heroin problem, then we've been dealing with the issue for a while. Am I right? So here's the other thing. We have issues that many people feel that Black Americans or African Americans have actually been left out of this whole new effort. Now, the intent may not be there. That may not necessarily be the case, but that's how people feel, to the point that many of our national publications are pointing to this issue. Here's another thing. 2 images of people struggling with addiction. Who is most likely to be perceived as a sick person? Who's most likely to be perceived as a criminal? And the reason why this is so important for us to consider is because in the year 2018, this should not be an issue. So why do we keep on reliving the same things over and over and over again to be able to come back to this same issue of why it seems that racial and ethnic minority populations tend to get the short end of the stick? Here's something else. My friend Myron Bennett would remember this because we worked in AIDS years ago. Do you all know that when AIDS first came about, it wasn't called AIDS. It was called GRID, gay-related immune deficiency, for some of y'all may remember, right? And it was a new disease. We didn't know what it was. People were scared. But we knew that there was one community that was really impacted by this. But then you fast forward it now, and the majority of the new cases of HIV infection are among young men, African-American men who have sex with men, followed by Latinos, and then the majority of the cases of HIV now are in African-American women. And so how is it that a disease that somehow or another really impacted, or we thought, one community is suddenly now a major problem for racial and ethnic minority populations? See, the reality is it's always been a problem. Even in the 1990s, when folks like myself and Myron Bennett and folks, even in the Hispanic Umadap, were addressing this issue, back then the minorities comprised 25% of the problem, but it was never thought about, it was never considered a problem that really, really impacted us, and it always has been. So when we start thinking about this whole issue of what determines health, we really need to change the way that we think about this. In this particular graphic, you will actually see the different life stages of women, in this case, it's Black women. Some of us have been, in a sense, educated to think that there is one issue that we have to deal with. Now, the number one cause of death in the United States is coronary heart disease. But you would think that that's not the only thing you have to deal with. If you look at the leading causes of death of African-American women from age 1 to 35, you will see that we can't just afford to focus on one issue. Now, the reason why the whole health inequities, the reason why some of those very diseases get out of control is because we don't have the necessary things in our living conditions in order to make you well. And money and education won't save you. If you are an African-American woman and you're a professional woman, you are more likely to have a poor birth outcome than a white female who has less than a high school degree. That is the reality of what we're dealing with. The other thing I just wanted to show you in this particular graphic, that when you, from age 1 to about 24, homicide is is among the top 5 causes of death for African-American women. But there's more. And so when we start talking about this whole health equity thing, how do we really think about this problem? Well, and I want to actually be able to characterize this based on the burden of disease in Cleveland's proud Latino community. Very rich culture, a lot of pride here. So one of the things I want to show you, in this case, this is a map that I created by census tract, and it shows areas where we have the greatest concentration of Latinos in the greater Cleveland area. In some cases, and the reason, by the way, I'm going to say census tracts instead of zip codes, you know why I say that? Because zip codes are designed primarily for the efficient delivery of mail. And so when you start looking at census geographies, like census tracts, it gives you a better way of comparing one geography to the other. The other thing about census tracts you need to know that a census tract usually contains around 1,500 to 8,000 people with the optimal size of 4,000. So if you ever really want to make a really good comparison, use census geographies like census tracts. But in this case, in some cases in the greater Cleveland area, we have census tracts that have a Latino concentration of almost 46 to 47%. This is just the same graphic with the percentages. So here's what I did. I kept the percentages so you know exactly where the greatest concentrations of Latinos are in the city of Cleveland. And then I actually put a map there on where you have the greatest concentration of coronary heart disease, which is, of course, the #1 killer of all Americans. And then if you actually look at the concentration, you would find out that the areas that we have the greatest Latino concentration is also the areas that we have the highest rates of percentages of coronary heart disease. So our question becomes, how do things get so bad versus they've always been this bad? Think about what I talked about, the miseducation. The other thing I wanted to ask you is, are we unintentionally perpetuating health inequities by some of our activities? And also, what types of thinking are needed to solve these health equity challenges? So this is some of the things that happens as those of you all who receive grants, you might experience this. Pick any disease, I don't care what it is. You apply evidence-based interventions, and by the way, evidence-based interventions are not bad, but you have to think about the context in which those evidence-based interventions take place. But you apply evidence-based intervention, maybe do some direct services. The duration of your intervention is going to be based on your funding. And then you hopefully will have a reduction of disparities if you're lucky. But then here's something else. You get some more money. Focus on the diseases you're funded to address. Apply your evidence-based interventions. And then what you do is you're going to try to sustain any progress that you made from your last grant. And then you're going to hope for the best. And then you have to tell your funder that the changes that were made based on the problem that you were supposed to address was based on things that you yourself did. Okay? Well, friends, we need a different type of thinking. We need to think about this holistically, and I want to just suggest a couple of ways for us to do that. The first thing is that we have to think not only about the problems that we're dealing with today, but we have to keep them within their historical context, and we have to be able to talk about what we vision as the future. We have to think about health. We have to think about the structures by which health take place. And we also have to think about the role of technology and how that impacts what we do. So what do I mean by this? We talk about the past, redlining, and de facto segregation. We think about what needs to go on in terms of the proof that the interventions are working. And you also really want to talk about values, because the extent to which we value the lives of racial and ethnic minority populations really pertain to exactly how much we invest in those communities. But you can't just stay in the past and talk about redlining. You have to think about what's going on in terms of mass incarceration, the economic injustice, poverty, and so there are some other things that we need to focus on in terms of that. But what does our future look like? We need people with a living wage. We need to think about educational attainment and what type of options do we have to build wealth. Now, we also need to actually have a vision of what health equity looks like. Out of all the times that you've ever heard anybody, I don't care where you've been, talk about health equity, have you ever had someone tell you what health equity would actually look like when we achieve it? And the reason why we can't is as if I had asked everyone here to draw an accurate picture of a Martian, even though you've never seen one. And so we have to be able to change our thinking in terms of a vision of what health equity looks like and what do we need to do to achieve it. So here's another example I want to talk about. Here you have this map again of coronary heart disease. I showed two areas, Cleveland, Ohio, and also Summit County. And the areas that I have in red and yellow show the greatest concentrations of African Americans, Latinos, right? Same thing we showed you before. But remember that I talked about change the way you think about this. So look at this, two areas, same problems, same patterns. And by the way, if you run this analysis on any major city in the state of Ohio, you will come up with a similar same pattern, right? But in terms of the miseducation that I talked about, if all you see are the disparities in these graphs, then it shows that we may need to expand our thinking. And I want to talk to you about this whole issue of structural racialization. Have any of y'all heard that term before? Okay, so let me just stop right here and just say this. Dr. Wade Nobles is credited, he's a famous African-American psychologist, and he is credited as saying this statement about racism that I'd like to actually share with you now. He said that you really have to understand the way that racism impacts our everyday lives. And he says if you don't necessarily take the time to understand the effect of racism on a grand basis, everything that you think you know will only serve to confuse you. And I think that that's what we tend to deal with. Now, we're living in a time where it seems as though racist behavior is coming in vogue. We're dealing with people who are going around doing some things that make us uncomfortable when they should, saluting Hitler, the rise of the KKK. And while that is certainly a problem and we need to keep in mind that those people need help and hopefully they will aspire to other things, those individuals in and of themselves are not causing these problems that we see in terms of health inequities. So, what do I mean by structural racialization? How many of y'all know the whole issue of redlining? Just by show of hands. Okay, but some of y'all who may not know, in the 1930s, during the New Deal, when the federal government wanted to actually make it possible for many Americans to afford homes, that's why we have this whole issue of home mortgages. Well, in order to be able for the federal government to agree to underwrite loans, what they did is they worked with many local realtors and they created maps on where they would actually, in a sense, guarantee these loans. And they would actually create these maps, and this one, of course, is of Cuyahoga County, of where it would be good for them to underwrite a loan. And so the areas in greens were the most desirable, followed by the blue. If there's an area that was yellow, it was thought of as declining. And then, of course, red is the places that they said you don't want to underwrite a loan. And the reason why those areas were red was because the presence of African Americans or blacks and then ethnic people. Now, this is something that we need to understand for a couple of reasons. Number one, it has actually structured the way our neighborhoods are today. But the other thing that's interesting about this is that it actually has defined, or the way that we thought about race has changed over the years. So if you were Jewish, if you were Armenian, if you were anything other than a white Anglo-Saxon Protestant, you weren't really considered white. And so now what happens is that over the years, while that has changed, the issue is that it has actually had implications for how we live. And so this whole issue of where chickens come home to roost, it actually has a real implication now. And so what I've done is I've outlined in black, let me go back, I've outlined in black the areas that were redlined. So watch this. Here is something I want to talk about. It's called the Health Opportunity Map. It's something that we're developing at the Ohio Department of Health to make available to you all. But what it does is it shows you areas of the county in which you have more of an opportunity to be healthy. And so the areas in blue are areas in the county where you have the greatest opportunity to be healthy. The areas in red are where you have the least opportunities to be healthy. And then if you look at the areas that were redlined and the areas that you have the worst or least opportunity to have optimal health, you see a difference. And so when we think about all of the areas that you all are familiar with that I talked about earlier, you know now that the suburbs and the neighborhoods that we have just didn't happen. They were created and then they were fortified by policy from the federal government that went on from the 1930s to the 1970s. But there's more. So, how do we really think about this and address it in a way that allows us to take action? I talked about this whole issue of a health opportunity index. Some of my friends in Virginia helped me with this. And what it is, the health opportunity index is a measure, a composite measure, that it takes 13 social determinants of health. That is data on conditions that we know drive health. And then we've actually taken this and we've actually run it through a statistical technique called principal component analysis. So what we did is we took all those factors, we actually combined them into this component analysis, and now we actually have a way of understanding what specific social determinants of health drive health opportunity. Now think about this. We can do this now for every census tract in every county, in every city in Ohio. Think of it this way in terms of how this works. Imagine, I talked about this whole thing about Martians. I don't know why I'm on this extraterrestrial thing, but let's just go with it. So imagine that a Martian came and stood right next to me and tried to give this presentation, right? And after, of course, you've seen this Martian, you'd go out into the foyer area and then there would be reporters. And they would want to know exactly what you saw in terms of the extraterrestrial being. Well, what would happen is the story that you would read in the paper is not about your individual descriptions. It would be the pattern that the reporter, it would be the pattern that she'd heard over and over again. So that, because out of all the things that we could say, there is an underlying truth. This is how this works. You can take all this data and put it together, and there's a structure, and that structure of that data tells you what's actually going on without all the noise. So here's what that means. I can take that health opportunity index, and by the way, we talk about social determinants of health, right? You all know what they are. Education, poor housing, right? Transportation, access to health care. And while you know that those things actually govern health, which one is actually causing the poor health opportunity in your neighborhood? This is what this tells you. You see that little box on the bottom? Those are scores. And based on those scores, we can tell you what drives the health opportunity. Now, I need you all to do one thing for me. I need you all to write down 3 numbers, okay? You all ready? 63, 81, and 82. I'll give it to you again. 63, 81, and 82. I want to actually show you how the new way of thinking that we need can actually guide us to action that we hadn't had before. Now, y'all are real quiet. Y'all all right? Y'all with me? Okay, because it's really about to get deep. Now, I told you that I'm from here. I grew up here. And I want you to visualize what I'm talking about. Okay, so here's an area I want to, let me just go back one moment. Now, the reason why I have that little circle, because there are 3 census tracts I want you to focus on. And the reason why I want you to focus on census tract, because we have one census tract that has very poor health opportunity, right next to a census tract that has moderate health opportunity, and then one that has really good health opportunity, okay? So this is an area that you all may know about. It's right off of Fair Hill and Martin Luther King. And you all know about the Baldwin Purification Plant, that really beautiful building, all right? So that is one of the areas that we want to look at. You all might know about some of the streets, Mount Overlook, okay, Woodstock Avenue, right? Okay. Then we actually have another area. You pass Fair Hill all the way up to Fairmount, going to Cleveland Heights. You might know some of the streets there. And then right after Fairmount, you pass Fairmount, and then you're into Shaker, and you might know some of the streets like, was it Meadowbrook and Scarborough? Y'all know what I'm talking about, right? Okay, I just want y'all to know that this is a real thing. Now, this is a simplified view of that. Now, what are those numbers I asked you all to remember? Give it back to me. Okay, in those areas, that is the life expectancy of those census tracts. In the area around the Baldwin Purification Plant, based on our calculations, you can expect to live anywhere from 63 years. Then for the one right next to it, 81 years. And life expectancy is 82. Now, you all have seen life expectancy calculations before. This is nothing new to you. But how can we actually address this? Remember I told you about that box, or that health opportunity index was pointing to what's really going on under the scene? We're saying that in order for us to create health equity and have better health opportunity, the score shows that we need to deal with 3 things: income inequality, job participation, and segregation. Those are the things that are actually driving the health outcomes based on this analysis in those 3 areas. But there's more. So if we look at this, we know that in the area around that Baldwin Purification plant, it has 57% African American, 39% white, and then you see the other percentages there. Now, we talked about what's going on, income inequality. If you look at the census tract to the far right with a population of 2,600, they actually earn 5 times the amount of money that the people who live in the Baldwin Purification Plant. The census tract right next to that, their median household income is 4 times the amount. Here's something else. When we think about just the demographic nature, we have a median age of 62 versus in the middle census tract, 27 and 44, as you see. But there's something else I want you to look at. The effective buying income is the amount of money that people actually have in an area in order to spend on goods and services. So in the area that has the ballroom purification plant, we're talking about $14 million in 2018 that they actually have going around that community. But then in the area that has the greatest life expectancy, we're talking about an effective buying income of $132 million versus $90 million for the one that has the moderate health. And so when we start talking about what the index will show us and what we have to work on, we know that we need to think about how do we deal with income inequality. Here's the other thing. We talked about job participation. Look at the unemployment rates in the areas that have the worst health opportunity versus the ones that have the best. Then when we start thinking about wealth, 79% of the people around the ballroom purification plant rent, while 61 and 89% of the people respectively own their homes. So now we're not just talking about the money that's circulating, but what do people really own to really build long-term wealth? We start talking about this whole issue of job participation, because of course, this is what the index told us. But think about this. 28% of the jobs in that area near Baldwin are in moving transportation versus 11% in terms of healthcare practitioners, nurses, people in the professions, and then the trade skills. As you look at that graphic, one of the things that comes to mind is that we have to not only think about how we are training people, but what do they actually have available to them for a living wage? I can tell you that the annual income for people who work in the transportation moving industry is about $30,000 a year. However, they need $46,000 a year for a living wage. These are the type of ways we have to think. So the question is, in terms of what have you done for me lately, when you think about who controls jobs, when we think about the education that's available to our people in those areas to be able to earn a living wage, what do we have to do to change this based on this information that you have now? Are you really willing to change your thinking about this? Are you willing to change your action based on your thinking? Here's the other thing, and I just want to be real clear. Unless we deal with those issues, and if we think about life expectancy, birth outcomes, chronic diseases, infectious diseases, and violence, you are not going to solve those issues unless you deal with the issues before: structural racialization, increased mixed income housing. And so what I'm saying is that we have to first not only question what we value, but we also have to focus on what are your policies that align with what your values are. The other thing is that you have to understand what drives investment, and as Director Dawson said, you have to hold people accountable. Now, y'all all right? Because y'all quiet and you're looking at me like I just said something wrong. All right, I'm almost done. So, remember that I said that we've never had an opportunity to really talk about what health equity actually looks like. So the current reality, if you think about the area and around the Baldwin purification plant, is that life expectancy 63 years, coronary heart disease, #1 killer, 16%, diabetes, cancer. You see all the percentages, right? In order for us to be able to achieve health equity, that's what it looks like. We would want to be able to increase life expectancy by 18 years. Coronary heart disease, we wouldn't have any more than 4%, followed by the percentages that you see for diabetes. The unemployment rate would only be 4.1%. And again, of course, the living wage of $46,000 is based on the population, because the median household size in that area is 2 people. So I want to just pause for a minute. I want you to think about this. And I want you to think about the reality. And by the way, the power of this type of thinking is you can do it for any place in Cuyahoga County. And the reason being is because you go from one census tract to the other, and the conditions which drive poor health may slightly change. And so if you sit back and say, I want to go ahead and increase education, because education is a really important social determinant, but education is not driving what's dealing with the health outcomes, then you might be applying the wrong solution to the problem that you're dealing with. Does this make sense? Okay, because we're almost done. The thing I need to tell you is nobody is coming to save you. So, and let me just say this real clearly. You know, I like Black Panther like everybody else. We got this thing about heroes, right? This happens to be, I think, Black Lightning. But the reason why I say that is because sometimes you don't want people to actually sell you a bill of goods that you can't take that you can't use. So a lot of times people will come in, I don't care, they could be from the government, business, and they're gonna say they're gonna save you. They're gonna offer you solutions. And I contend that if anyone comes and tells you that they're gonna save you, at best, they're very naive about what actually is driving the problems that you experience. And at worst, they're lying to you. You all in Greater Cleveland have the power and responsibility to save yourselves. See, nobody can come in and do for you what you can only do for yourselves. The other thing that you have to understand about this is that government and leaders actually have a responsibility to you. We have a responsibility to make resources available to you. We have a responsibility to be able to make funding and data and everything else that we have to offer, because after all, we work for you. You don't work for us. However, stop thinking that there is somebody going to come in and do this thing for you. As much as I love Cleveland, I'm from here. I can't save you because I don't live here anymore. But you all actually have the power to actually be able to do it. So the reason why I want to actually talk about what Frederick Douglass said, power conceives nothing without demand, is because you all actually have, I think, some decisions to make in the very near future and also the very far future. This means looking at those individuals who control the resources that control the things that we need to stay healthy. It's about making people in the government and politicians accountable. So if you don't make your voice heard, whether or not it's calling to your state representative or actually going to people that you do business with and demanding more, it won't really concede any demand. You have to understand not only what the demand is, but you have to have enough information to make sure that your demands are actionable. Otherwise, what they will do is to say, well, you know what? We've seen these problems before in racial and ethnic minority populations. Nothing's going to change. And here is the danger to this. I just showed you a way of using data and information to make an effective argument in terms of what changes. And the reason why you have to base a lot of your work on what you know to be true and you back it up with data, because there are some cases where people will say, I spent millions and millions of dollars on issues for racial and ethnic minority populations, and nothing seems to change. We don't want to ever give the impression that the problems or the core of racial and ethnic minority populations are so bad that they are beyond repair. It's not that the communities that we serve are beyond repair. It's just that our thinking and our actions have not been appropriate for the problems that we need to address. And if we don't challenge people, and this is what they'll say, you know, Ohio spends more money, and which is true, we spend more money on health care than I think so many other states, but we don't get the health value, and that is true. But unless, and I tell my colleagues at the state here this all the time, that unless you deal with this whole issue of health disparities and health inequities, unless you start dealing with the social determinants of health, everything that you think you want to achieve is not going to work because you haven't gotten to the root cause. And I will say that until I can't say it anymore. Here's my last slide, I promise. The other thing is, look, you are all you've gotten. We need everybody in terms of this issue. Now, in this case, I saw this graphic. It talks about how communities will unite around the opioid epidemic. But you know what? You all are dealing with so many other issues. You can't just deal with opioids. You have to deal with stroke and homicide and unintentional injury and cancer, all of these things that you have to deal with simultaneously. You don't have the luxury of just dealing with one problem. And so what does this mean? It means that we need everybody. Now, for some of you all, these things are so bad that you just probably want to drop to your knees and pray. And that's all right because it's okay because we need God in this situation. That means we need Jews, we need Muslims, we need Christians, we need Buddhists. But you know what? It may be an issue that you don't believe in God. Maybe you're an atheist or maybe you're agnostic. And that's okay because we need you too. And so if you don't necessarily believe in God or God of a higher power of your understanding, then at least believe in your ability to actually fight for social justice and equality for people who can't get it in and of themselves. We need everybody, everyone. We need straight people, gay people, transgender, people who are non-gender conforming. Because the reality is that the issues that we talk about are coming for all of us. No one is exempt. No one should be left out of the equation. What that means is that you might have to work with some organizations who got on your last nerve. You know, the ones who probably got that funding that you should have gotten, you know, and they always get the recognition. But you know what? And while some of those issues may be true, we have to find a way of actually coming together because we've all we've got. My last statement is that this is believe land. Anything is possible, right? So if this is believe land, my question to you is, are you really ready to meet this challenge? Are you willing to change your thinking and embrace a new way of doing things and challenge people who need to be challenged? Are you ready for the challenge? Of course you are, because this is believe land. I'm counting on you, Northeast Ohio, and I don't think you'll let me down. Hey, thank you for listening.
Thank you, Chip, for talking about the Health Opportunity Index and how we can better use data to approximate what we need to do in our communities. We're going to give the audience an opportunity to ask any questions. There were index cards that came around to your table. If anybody has any questions that they would like to ask Mr. Allen, you can do so at this time.
So if you have any questions, please raise your hand with your note cards, and we'll collect those.
Okay, the first question that we have, Chip, is where can we find Health Opportunity Index?
Well, believe it or not, you are the first group to ever actually see it in Ohio. So, yes, you are. In this one. So, we are hoping to actually have it widely available for everyone on one of our websites within the next few months. We are actually just trying to make sure that we can put it in a way that people can get to it. The other thing is, so give us about 3 months and it should be up and running. The other thing is, if you all want webinars or ways to actually be able to think about how to use it, because we can actually walk you through how to use the index for any given area, we'll do that. It's just not optimized for everyone's use. We want to let you know that it is coming and will be available, and it'll be available to you in a few months.
How do we better match funding sources to address social determinants of health versus traditional disease-specific funding?
A lot of times when we think about who's actually working on a particular issue, your funding guidelines might say you only deal with one thing. And so I think that's the value of the partnerships, that you actually get with a cross-section of, like in this case, you all have a broad-based coalition, to be able to find people who actually have either flexible funding or can do things that your funding restricts you to do. The other thing is that you'll hopefully see that in so many of your funding applications, they're going to talk about how do you address social determinants of health. So they're not just, they may be disease focused, but they may have a provision in about how do you deal with disparities and inequities. And you can use that intersection to be able to work on things with your partners. At least that's the strategy that we've actually been also using at the Ohio Department of Health. But look at, anytime they say address social determinants of health, that is your key to actually be able to do some things that you traditionally have not done.
Chip, you spoke to the responsibility of all of us, specifically health systems, to address inequities. How can we convince our major systems in Cleveland to address the social determinants to improve the health of populations?
Thank you for the question. Excellent question. As all of you all know, that most healthcare systems have to do a community health assessment in order to keep their 501c3, their tax-exempt status. And so they have to do that on a periodic basis. And they're supposed to actually come to the community and ask, what is it that you all think needs to be done? That is your opportunity to do a couple of things. Is to be able to, and by the way, some of the data that I showed, there's a really good site called Community Commons, where you can actually make the maps that I showed you and to be able to actually have good data. And so when the health system is actually looking at those downstream approaches of how they provide good care, it is up to you, for those individuals who understand health equity, to make them understand that all the different health goals that they want for their organizations, all their profit margins, anything that they really want to be able to do is not going to occur in the manner that they want unless they deal with this whole health inequity issue. And so for health systems, not only tackle on that community needs assessment, but make sure that the coalitions and the individuals who understand the type of social determinants of health that we're talking about are reflected in that plan. So you will know that you've done really a good job, is that not only if the health system has included not only a recognition of the social determinants of health, but within their sphere of influence, what are they willing to do to tackle it, not only within their own resources, but to use their influence to address that as well.
And this is our last question. Chip will be here. You'll be here for the remainder of the day. So if there are questions you want to approach him with, he will certainly be here. And yes, we will make his slides available to you. The last question is, even though there is money in poverty, how can we bring money for housing in low-income areas to people who want to become first-time homeowners?
There are a number of organizations that are actually making money available to first-time homeowners. I think you can go to, some of them do not come to mind. I'm sorry? Dollar Bank. Well, yes, there are a number of, so I guess what I'm saying is, first of all, work with your local lending institutions. Also, I know that the Federal Reserve Bank here is doing some really good work in terms of addressing these types of issues, long-standing issues that we've been dealing with. The other thing that you also want to do is, when we think about housing, one of the things that we know, and it was based on the subprime loan crisis, is that now there are all these either abandoned homes or areas in the city of Cleveland that are now being torn down, and we are having all this land. Now, I can tell you, out of all the other things that they're making, the one thing that they're making no more of is land. So what that means is that go to your city planning office and actually understand or find out what are the short and long-term development plans that the cities have, what is being zoned, what is not being zoned, and then be able to use that so that if there's an area that may have been residential, but because of the demolition of these houses, they have this land bank, use your voice to actually be able to go into the city plans because they're available. See, they know exactly, most cities know exactly what their short and long-term investments are for the development of the municipality for years out. The question is, how do you get into that planning process to make sure that when they actually make those plans, that health is, first of all, they have health in mind, but they also, that they can find out, and I think the question was housing, where are the new housing developments going in? One of the things that I didn't tell you about the whole issue about that whole, first of all, there's a lot of pride and good things going on in the area in terms of the Baldwin Purification Plant. I just want to be able to say that because a lot of times when we actually present data like that, there are a lot of people who get real squeamish because they think that you're putting blight or that you're actually disrespecting community. We're not doing that. We're saying that these are the problems and these are the problems we need to fix. But in that particular area, one of the factors that we use in the Health Opportunity Index is one called population churning. And what it means is how often do people move in and out of an area. In that area around the Baldwin Purification Plant, the population churning index is very high, which means that not only is there poverty, but the poverty is stable. You don't have people moving in and out of that area. And so when we start talking about the question of housing, we have to start thinking about how can we have or create mixed income communities. And so that you actually have people that can actually bring more wealth not only into the area, but they're also diversifying the tax base. But your city plans are the way to start that. I think that is the last question, but I will be available throughout today. Thank you again.